So shall we start? And good evening, ladies and gentlemen. Welcome to this APSR COVID-19 educational webinar hosted by the Asian Pacific Society of Respirology. I'm David Lam, current president of the APSR, and we are most delighted to have this opportunity to bring to you today's educational webinar entitled Revamping Pneumonia Diagnosis and Antimicrobial Stewardship with Advanced Molecular Diagnostic. And we are most grateful to have the opportunity to work together with Biomurin's aspect to bring you this educational webinar today. Before I go on further introduction, I would just like to remind the participants that we have the option of live transcription today, and you can see there is an instruction right now on the screen that the option will equally be available on your participant screen. When you select the option, you will get the live transcription of the talk today. And before I hand over to the chair of the meeting today, Professor Song Waning from China, I would like to invite Dr. Nick Chia, who is currently Vice President of the Medical Affairs of Biomurin's aspect, to give us an opening remark. Dr. Chia, please.
Thank you, Dr. Lam, for the introductions. So on behalf of Biomurin Asia Pacific, I would like to welcome you to the webinar on revamping pneumonia diagnosis and antimicrobial stewardship with advanced molecular diagnostics, to be presented by Dr. Tawfiq Assad. Biomurin is happy to sponsor this educational event together with the Asia Pacific Society of Respirology. As the world leader in the field of in vitro diagnostics for over 55 years, Biomurin is present in 44 countries and serves more than 160 countries with the support of a large network of distributors. Biomurin provides diagnostic solutions which determine the source of disease and contamination to improve patients' health and ensure consumer safety. BioFire is the leader in syndromic infectious disease testing with more than 25 years of molecular experience, and as Biomurin's Global Center of Excellence for Molecular Diagnostics, BioFire sets the standard for molecular diagnostics through its pioneering advances in syndromic infectious disease testing. I look forward to listening to the presentation by Dr. Assad and hope that the learnings and knowledge which you will gain today will help you to alleviate the patient's sufferings and enable them to live a healthier life. Thank you.
Thank you, Dr. Chia. We are going to hand over to our chair for the meeting today, Professor Waning Song from China. He's currently the head of the assembly of the APSR Respiratory Infections Non-TB section. Professor Song, please.
Thank you, Dr. Lam. So it's my pleasure to welcome Dr. Tawfiq Assad for today's talk. So I will introduce Dr. Assad first. So Dr. Tawfiq Assad is a board-certified internist, pulmonologist, and critical care intensivist, serves as the director of the critical care and lung nodule program at the Williamson Medical Center in Franklin, Tennessee. During his internal medicine training, Dr. Assad served as the chief medical resident at the Boston University Medical Center, while completing a fellowship in pulmonary and critical care medicine at Vanderbilt University. Dr. Assad also earned a Master of Science in Clinical Investigation. So it's our pleasure to welcome Dr. Assad. Please, Dr. Assad.
Let me share my screen. Okay, hope you guys can see the screen clearly. Thank you so much to the Asia Pacific Society of Respirology for having me. I'm Tafik Assad, and as you heard, I'm an board-certified pulmonary critical care physician and internist. And I'm going to spend some time speaking to you guys today about how rapid multiplex PCR technology can help revamp your ability to diagnose pneumonia of all types, community-acquired, hospital-acquired, and in the COVID-19 era, SARS-CoV-2 pneumonia, and contribute to your ability to have antimicrobial stewardship at your institutions.
Dr. Assad, can I request you to switch the screen because we are looking at the presentation view?
Hold on one second, I'm sorry. Is that better?
No. Yeah, duplicate.
Swap presenter view. Is that any better or no?
Is the next one duplicate the screen? Go back to the display setting again. Yeah, the next one down, duplicate.
Oh, I see. Sorry. That help?
You need to share again.
Okay.
Sorry about
trying. Sorry for the technical difficulties. Let's share. It worked earlier. Hold on one second. I apologize for this. Let me try to just stop sharing and then start over. Okay, I apologize. Is this presenter view or is this the correct view?
It's the presenter view, so you need to duplicate.
I tried that and that seemed to, normally it's swap presenter view and slideshow so that you can see the other screen. That's not fixing it?
Yep, it's better now, Yep.
Okay, so sorry guys. Small little glitch, but we'll get through it. Okay, so as I said, I'm going to discuss with you first off, an overview on pneumonia. So talking to you in general about the epidemiologic concerns and the way that we treat pneumonia. And I'm going to skip the diagnostic challenges until afterwards and talk to you about the current limitations in the way that we diagnose lower respiratory tract infections and the limitations of the quote unquote gold standard of this diagnostic modality, which is sputum culture. I'm going to then transition to a discussion on rapid multiplex PCR technology as a means of rapidly diagnosing and excluding specific viral and bacterial pathogens, and how the data has shown it is far superior to conventional sputum culture and diagnostic techniques for diagnosing lower respiratory tract infection. And given that we are in the midst of a global pandemic from COVID-19, it's hard not to spend some time speaking about the association between COVID-19 infection and bacterial pneumonia. And lastly, I'm going to go through 4 separate cases, all highlighting something slightly different about the role of rapid multiplex PCR technology and the ability to diagnose a variety of types of lower respiratory tract infections. So starting from the top, pneumonia is one of the most common diagnoses that urgent care, emergency room, outpatient, hospitalized patients are diagnosed with globally. Almost 1/2 billion cases are diagnosed on an annual basis. It is not only common, but it is also quite deadly, and is the 4th most common cause of death in the entire world and the #1 most common cause of death in lower income countries. This is very old data from a decade ago from the United States, but it is not only deadly, but it is quite expensive, with healthcare costs on an annual basis over $10 billion. Luckily, hospital and ventilator-associated pneumonias are far less common, with an incidence rate of 140,000 per year for hospital-associated pneumonia, and ventilator-associated pneumonias much more of a dose-response relationship in that the longer that a patient is ventilated, the much more likely that person is to develop a ventilator-associated pneumonia. But although not very common, hospital and ventilator-associated pneumonias are significant causes of morbidity and mortality for hospitalized patients. Now, pneumonia is generally caused by the inhalation of respiratory droplets. We've all thought about this a great deal in the COVID-19 era, but probably more commonly, particularly for lower respiratory tract bacterial infections, it is commonly caused by the microaspiration of pathogenic microorganisms from the upper airways. We oftentimes think about lower respiratory tract infections by categories in terms of the types of infection that they represent. So starting with what is thought to be one of the more common causes of pneumonia, bacterial infection, we oftentimes cluster these into where the patient contracted the pneumonia. So community-acquired pneumonia versus a hospital or healthcare associated pneumonia. For community-acquired pneumonia, bacterial infections tend to be caused by strep pneumonia, Haemophilus influenza, Moraxella, or one of the number of atypical bacterial pathogens listed below. For hospital-associated pneumonia, patients are more susceptible to one of the more resistant bacterial pathogens, such as Staph aureus in terms of gram-positive microorganisms, and a number of the resistant gram-negative rods, such as Klebsiella, Pseudomonas, Acinetobacter, Enterobacter, etc. Now, obviously, patients in the community occasionally do develop a more resistant lower respiratory tract infection from a pathogen thought to be more hospital-acquired. And conversely, patients who are hospitalized sometimes develop infections while they are hospitalized from a more sensitive pathogen. But these are, in general, the more common in terms of epidemiologic studies. Now, in terms of viral infection, historically, prior to 2019, 2020, influenza was thought to be the most common respiratory virus that can lead to a lower respiratory tract infection. But obviously, we all know very well now that any respiratory virus, specifically coronavirus, can lead to a severe lower respiratory tract infection. But essentially, any one of them on the list can do it. Now, lastly, there are a number of other infections, fungal, mycobacterial, parasitic, that depending on where you live and where it is endemic and patient risk factors could cause a lower respiratory tract infection, but generally not common causes of infection in immunocompetent patients. Now, how do we treat pneumonia? Well, I skipped diagnosis for a reason, and we're going to get to that just in a moment. But in general, we are unable to diagnose the specific pathogen, and we tend to treat lower respiratory tract infections empirically with antibiotics. Now, we decide which antibiotic to use based on a number of factors, such as where the patient contracted the pneumonia, as described before. If they were community patients or ones who were hospitalized, that somewhat determines whether or not they are more likely to have a resistant pathogen. We also are asked to consider the severity of their illness and whether or not they have risk factors for resistant pathogens such as MRSA or multi-drug resistant gram-negative rod infections, and choose antibiotics accordingly. Now, the problem is, as I've already told you, one of the more common causes of a lower respiratory tract infection is a viral infection. So oftentimes antibiotics are not required. In addition, oftentimes we give excessively broad antibiotics because we do not know the specific identification of the pathogen leading to the lower respiratory tract infection. And so there are many opportunities for an MD, using your hospital's antimicrobial stewardship means to give patients less potent antibiotics. But unfortunately, because of our inability to effectively diagnose lower respiratory tract infections, we oftentimes give excessively broad treatments. So let me spend some time talking about the current modalities for diagnosing lower respiratory tract infection and the limitations in them. Now, pneumonia is typically clinical diagnosis. And by that, I mean there's not one test, and there probably never will be one test that tells you if a patient has pneumonia and which type. We diagnose pneumonia based on a consistent set of symptoms, such as cough, shortness of breath, fevers or chills. In terms of imaging findings that are characteristic, this is a chest x-ray or a CT scan, which demonstrates an infiltrate. The problem is that for the imaging findings, there are non-specific changes that can be seen on chest imaging that do not help guide the clinician as to whether the patient has a lower respiratory tract infection or an alternative cause of infiltrates, and if they have one, whether it's a virus or a sensitive bacteria or a resistant bacteria. Then we rely on some laboratory testing, such as routine lab testing, like an elevated white blood cell count, elevated inflammatory markers, etc., which can be useful, but again, are very nonspecific. These are very insensitive tests. So we are supposed to rely on microbiologic testing that is dedicated to lower respiratory tract infections to help guide our antimicrobial decisions. Now, this is true all the time, but has been particularly true in the COVID era, that symptoms, imaging findings, routine lab testing are extremely insensitive. And so we do really have to rely on excellent microbiologic testing to guide our treatments. Now, when I talk about microbiologic testing for pneumonia, I'm talking about, first off, procalcitonin. As you all very well know, this is a biomarker which is oftentimes elevated in bacterial infection and lower in viral infection. Now, this can be useful, but unfortunately, oftentimes we have found that procalcitonin can be marginally elevated in the setting of severe viral illnesses, such as COVID-19. The gold standard for diagnosing a lower respiratory tract infection is the sputum, gram stain, and culture, other cultures such as blood cultures as well. There are a number of antigen testing on urine or blood specimens, such as strep pneumonia or Legionella pneumophilia, which oftentimes can be useful but take several days to return and are quite insensitive. Not quite as useful in clinical practice, but certain bacterial infections have serologic tests, such as mycoplasma, which is occasionally used, but not very relevant because they take too long. And then there are nasal swabs looking at antigens or PCR testing for single viruses, such as influenza, RSV, SARS-CoV-2, or single bacteria, such as an MRSA nasal swab, or multiplex panels of nasal pharyngeal swabs looking at multiple viruses and bacteria. When I talk about the standard dedicated microbiologic testing for lower respiratory tract infections, this is what I'm referring to. And as I said, sputum, gram stain, and culture is thought to be the gold standard, the backbone. Now, the problem is that the yield of sputum culture, the so-called gold standard of diagnosing lower respiratory tract infection, is abysmal. Study after study has shown that the yield approaches 10% if you look at all comers. Now, in some circumstances, obviously yield can be higher, like such as a bacteremic patient or an immunocompromised patient who has a very high bacterial burden inside their lower respiratory tract. And you can obviously combine multiple test modalities, such as a sputum culture, and then a procalcitonin, and an antigen test, and a PCR to improve your yield. But then you're ordering multiple tests one at a time, which can be confusing, and it delays the results of your test. Now, also, one thing to keep in mind is many patients, despite their best efforts, are just unable to provide a high-quality sputum specimen, and that is another problem that we occasionally see. Now, the role of sputum culture is so limited that the American Thoracic Society and the Infectious Disease Society of America, and their combined 2019 guidelines on diagnosing and treating community-acquired pneumonia, actually routinely discourage the use of sputum culture unless patients have very severe community-acquired pneumonia or a suspected multi-drug resistant pathogen, such as hospital or ventilator-associated pneumonia. Now, what they did say in those same guidelines in 2019 is that rapid, cost-effective, sensitive, and specific diagnostic tests are the future of diagnosing lower respiratory tract infections in order to target therapy appropriately. And more recently, in 2021, in their guidelines on community-acquired pneumonia, the American Thoracic Society suggested that in inpatients who are immunocompromised or in inpatients who are immunocompetent but have severe community-acquired pneumonia, to consider nucleic acid-based diagnostic tests, such as multiplex PCR, in our ability to improve the diagnosis of lower respiratory tract infection and in antimicrobial stewardship. And this is a nice segue to talk about rapid multiplex PCR pneumonia technology. Now, there are obviously a number of different companies out there who make a number of different products. Some of these details are going to be specific to the product that I'm more familiar with, bioMérieux, but there's a lot of overlap between this panel and a number of other panels. And so rapid multiplex PCR technology generally employs an automated system in which nucleic acid samples are extracted and purified from specimens. Now, multiplex PCR technology is getting better and better. And so most of these are able to identify multiple viral and bacterial DNA targets within only an hour of resulting and only 2 minutes or so of sample handling time. Now, the panel that I'm familiar with is a multi-modal panel. And so there are a number of different tests that can be run on a number of different body fluids. Specifically, there is a blood culture panel, which can be run in the setting of a positive blood culture, a meningitis and encephalitis panel, which can be run on cerebral spinal fluid for suspected meningitis and encephalitis, a gastrointestinal panel, which can be run on stool specimens, an upper respiratory panel, which can be run on nasopharyngeal swabs. And what I'm going to spend the most time talking to you about is the pneumonia panel, which can be run on multiple different lower respiratory tract specimens, specifically an expectorated sputum, an endotracheal aspirate for a patient who is on mechanical ventilation and has an endotracheal tube, and a bronchial alveolar lavage. Now, there are a number of different tests and a number of different modalities and panels, and so it's hard to give you one number. But in general, for most pathogens, the specificity and sensitivity of these panels are excellent. Now, if you look at the very bottom, there's some infographics that help to demonstrate some of the workflow and just the way that these panels work. So starting on the one on the left, you can see as soon as you insert a pouch, which I'll go into in a second, the pouch is really the backbone of these tests, into a loading station. You inject a hydration solution at one place, you inject the specimen in another place, and then you load that pouch into the machine, depending on what modality you have. It depends on the machines will vary somewhat, but you load the pouch into the machine, you press run, and results are generally resulted within 45 minutes to an hour. If you look to the right, this is supposed to be a little representation of how these pouches are so powerful. They're essentially miniature laboratories all rolled into one. So starting at the very left, you can see, although the type is small, that there is a sample injection port as I described. And then the sample sort of moves through the pouch sequentially, first undergoing cell lysis, and then DNA, RNA purification, and then PCR, and then more PCR and multiplex PCR occurs, and then results are generated. So spending some time talking about the pneumonia panel that I'm most familiar with, this is what you get when you order one of these tests. There are in total 33 different viral, bacterial, and antimicrobial resistance targets every time you order this test. Let me go through what are some of the results that you get. Starting at the left, there are 8 respiratory viruses on this panel. And you can see that coronavirus is on there, but at the moment, this is not SARS-CoV-2. This is the seasonal coronavirus, influenza A and B, and all of the other viruses that you see. There are 3 what I call qualitative bacteria: Legionella, Chlamydia, Mycoplasma. These are the more common causes of atypical bacterial infection that lead to lower respiratory tract pneumonia. And so the 8 viruses and the 3 qualitative bacteria are reported as detected or not detected. And that's the level of detail that you get. But for these 15 bacteria in the middle, which are listed in alphabetical order, these are resulted in a semi-quantitative manner. And what I mean by that is that you don't just get a report that Acinetobacter or Klebsiella or Staphylococcus aureus are detected or not detected. If it is detected above 10 to the 3.5 copies per ml, it gets reported in its relative bin value, which is reported as 10 to the 4th, 10 to the 5th, 10 to the 6th, or greater than or equal to 10 to the 7th copies per ml. And so that is not quite the same as a colony forming units result that we're all familiar with culture data, but a similar sort of representation of the relative amount of bacteria within the specimen. And again, if it is detected but below 10 to the 3.5 copies per ml, it is reported as not detected. Lastly, there is some very valuable information on antimicrobial resistance. So starting off, maybe the most important of all, for Staphylococcus aureus infections, if the MEK-A/C and MREJ genes are detected, it is reported as MRSA. There are 5 carbapenemase genes, including the KPC gene, and the most common cause of ESBL, the CTXM gene, reported. Now, these antimicrobial resistance genes are not the same as standard antimicrobial resistance testing done in a microbiology lab, but merely the report of the presence of these genes, the common genes that cause these antimicrobial resistance, in the presence of a corresponding bacteria. So the MEK-A/C and MREJ gene will only be reported as positive if a Staph aureus species is present, and the same goes for the carbapenemase and ESBL genes. They will only be reported as positive in the presence of an associated gram-negative rod. And so I'm going to spend some time talking about one study which really highlighted the superiority of multiplex PCR technology compared to culture. So the study that I'm referring to was published in 2020, in which almost 850 patients had either a BAL or sputum specimen run in one of the 8 academic medical centers, including pediatric hospitals, between 2016 and 2017. And what they did in the study at these 8 hospitals, if a sputum culture or a BAL culture was ordered by an ordering physician for any reason, and if there was a leftover specimen that was fresh and never frozen, the specimen was then sent to a reference laboratory, which then compared the pneumonia panel result on that patient's specimen to what they called comprehensive culture. Just to let you know what comprehensive culture means, for every specimen that they plated it on 4 different media types at 4 different concentrations. So that means there was 16 different plates for every attempt to culture one pathogen, okay? And that is compared to an hour run on the pneumonia panel. And what the results found were really staggering. Starting at the left, looking at the sputum specimens first, just to walk you through, because this is there's a lot of numbers in a busy slide, but in 39% of cases, both of the modalities, the pneumonia panel as well as the comprehensive culture, did not detect a pathogen. In 34% of cases, both modalities were able to identify the same pathogen. And so those are the situations in which the testing was concordant. But in 27% of cases, the pneumonia panel was able to identify a bacterial pathogen, whereas comprehensive culture could not. And in only less than 1% of cases, a few cases total, the opposite was true, where the culture found something that the pneumonia panel did not. If you look at the BAL specimens, in 62% of cases, both were negative. In 16% of cases, both were positive. And in almost a quarter of the cases, 22% of the time, the pneumonia panel found a pathogen, whereas comprehensive culture did not. And again, in less than 1% of cases, the opposite was true. Now, don't forget that in the pneumonia panel, you also get data on antimicrobial resistance, which they didn't report in the study, but also on respiratory viruses. And in almost a third of cases in the sputum specimen, in many of them in which there was no bacterial pathogen identified at all, a respiratory virus was found. And in 16% in the BAL, also a respiratory virus was found. And so when you're comparing what I would describe as far more vigorous culturing than what we do in our routine microbiology lab, which takes hours and days and it's labor intensive, to a panel that is run in 1 hour, the yield on the pneumonia panel doubled or tripled compared to comprehensive culture. Now, since over the past few years, since 2018 and beyond, there have been a number of clinical studies which have looked at the relative performance of rapid multiplex PCR technology compared to culture. And so a number of them show that the positive % agreement and the negative % agreement between culture and the pneumonia panel are fairly excellent. Now, numerous studies have found that any pathogen, whether that be a virus or whether that be a bacteria, was detected on a specimen anywhere from 60 to 90% of the time. And when you compare to the yield from culture, the yield from culture in some studies was not changed by much, but in some studies was improved by almost 40%. And so I think it is very obvious that the multiplex PCR technology is far superior to culture in our ability to detect bacterial pathogens and viral pathogens. Now, one thing that I want to point out, this is a limited panel. And so I told you there are 33 targets, which is amazing, but there are obviously going to be some bacteria which are not labeled present on the panel that may cause lower respiratory tract infection in your patients. Here are some of the more common ones: Burkholderia, Citrobacter, Enterococcus, Haemophilus parainfluenza, Stenotrophomonas. So keep in mind that if you have a very high suspicion for a lower respiratory tract infection and the pneumonia panel is negative, if you choose to order it, that there is still the possibility of another type of bacteria which is not on the panel being present. So obviously, as always, you have to use your clinical judgment and all of the information in hand. A number of studies have found that antibiotic or isolation changes could be made anywhere from 40 to 70% of the time. And so that means escalation of antibiotics or de-escalation or discontinuing antibiotics altogether. And in some cases, adding isolation precautions because a multi-drug resistant pathogen such as MRSA or some gram-negative rod was identified. And that some studies found that antibiotics would be given far less to patients as we're able to de-escalate and discontinue more often. One study found that if you compared their previous model, which was to perform a number of ancillary tests, such as nasal PCR, antigen testing, culture, this and that, they were actually able to save patients by discontinuing their previous model and just ordering the pneumonia panel on all patients. And lastly, not every study, actually used this as an endpoint, but all of them would have found this if they had studied it. The turnaround time when you're talking about a pneumonia panel compared to culture, which takes anywhere from 2 or 3 days or maybe longer depending on your lab, is improved by anywhere from 44 to 62 hours. Okay, again, that was all about the multiplex PCR technology. I wanted to spend a little bit of time talking about COVID-19 because there's a big overlap now, and this is always fresh on people's mind. How does lower respiratory tract bacterial infection intersect with COVID-19 pneumonia and the role of antibiotics in this era? So I think just before I talk about COVID, it's important to talk about viral pandemics and bacterial pneumonia, which is a very well-established clinical phenomenon from numerous viral infections in the past, that there were secondary bacterial infections caused in the setting of severe lower respiratory tract infections from endemic or pandemic respiratory viruses. Most notably after influenza pandemics, there was 1918, 1957, 1968, and the H1N1 2009 influenza pandemics. We were seeing a number of patients develop significant morbidity and mortality, actually not from their viral pneumonia as much as from a secondary bacterial infection. And several coronavirus endemics before, such as MERS and SARS-CoV-1, particularly for patients that were ill in the ICU, there were increased reports of bacterial pneumonias as well. But ultimately, any lower respiratory tract viral infection, anywhere from RSV to rhinovirus to influenza, can lead to increased adherence of upper respiratory tract bacteria and secondary bacterial pneumonias. And so when we look at some of the initial data that has started to come out after COVID-19 came out, we actually found that co-infection, so at the time of diagnosis, was thought to be fairly uncommon. So when patients were initially diagnosed with their COVID infection with SARS-CoV-2, most of those people did not have a lower respiratory tract infection. But when you really start to dig into the data, you'll find that as patients become more ill, and certainly as they develop respiratory failure requiring mechanical ventilation, their risk of bacterial infection secondary to their COVID-19 infection rise significantly. And so at all hospitalized patients, about 6%. All patients in the ICU, about 16%. But when you're starting to look at patients on mechanical ventilation, depending on the study, anywhere from 35 to up to 50% of patients developed a secondary bacterial infection after their COVID-19 infection, and many of these patients suffered significant morbidity and mortality from their bacterial pneumonia. And so there has actually been a meta-analysis that looked at the role of multiplex PCR technology in COVID-19 infection, COVID-19 patients. This was a compilation of 7 studies, almost 600 patients. And one interesting point is that many of these patients, which is commonly early in the pandemic, received empiric antibiotics even without the detection of any lower respiratory tract bacterial infection prior to them getting tested. When you compare the multiplex PCR pneumonia panel in all of these patients, and this included some ICU, some ventilated patients, some who were on the floor, so really kind of a hodgepodge, you can see that the multiplex pneumonia panel improved the ability to diagnose a lower respiratory tract bacterial infection by almost 2-fold. And as I said before, turnaround time, not surprisingly, markedly improved anywhere from 1 to 2 days. So now, after I've gone over how we diagnose pneumonia, how we should diagnose pneumonia, and the role of lower respiratory tract bacterial infections in COVID-19 patients, I'd like to just go over 4 cases from my clinical practice. These were real patients that I've seen within the past 1 or 2 years, in which I believe that rapid multiplex pneumonia technology has really helped my ability to diagnose lower respiratory tract infection and contribute to antimicrobial stewardship in my institution. Okay. My cases are titled in ways that are somewhat leading. So case number 1 is called Antibiotics for Every Community-Acquired Pneumonia. This patient is 66, who came to the hospital with lower respiratory tract syndrome, fevers, chills, and cough. He had symptoms for about a week and then eventually came to our hospital and was febrile and was wheezing and was hypoxemic. And so he came to the ER and was ultimately admitted with community-acquired pneumonia. His chest x-ray, as you can see here, demonstrates a markedly elevated left hemidiaphragm. He's got left basilar atelectasis as a result. He probably has some increased interstitial markings, and there was possibly increased infiltrate in his right lower lobe and left lower lobe in the setting of his atelectasis. So I was not involved in his case earlier on in his admission, and he was initially, sputum culture was ordered, but he was unable to expectorate any phlegm. He remained febrile, so he was given an antibiotic to treat community-acquired pneumonia, specifically levofloxacin. 2 days later, he was eventually able to cough up a fairly sizable amount of sputum. He had a pneumonia panel ordered, and it was positive for human metapneumovirus. And so at that moment, antibiotics were immediately discontinued. This clearly was a patient who had questionable lower respiratory tract bacterial infection. He didn't have a very compelling infiltrate, but he was symptomatic, and so started on antibiotics. But once we found the presence of a lower respiratory tract viral infection, we obviously changed our focus. No antibiotics are helpful. We put him on steroids, nebulized bronchodilators, and focused on airway clearance. We weaned him off oxygen, tapered his steroids. He improved and was discharged home. So this is a very simple case. But if you have the ability to confidently diagnose a lower respiratory tract viral infection, we would just give far fewer antibiotics because we know they don't help in this case. And we were able to target our treatments appropriately. My second case is titled, How Many Bacteria? So this is a patient who I saw relatively recently. I think this was a couple months ago. He was 76, comorbid with a number of problems. He has COPD, he had bronchiectasis, he has significant GI issues in the form of Barrett's esophagus and severe esophageal dysmotility, who actually came to the hospital for an elective skin tumor resection, but this required general anesthesia. Did fine during the surgery, but in the PACU after his surgery was found to have large volume aspiration. So unfortunately, the patient gradually worsened in the PACU. He became more hypoxic, he was tachypnic, he had very high work of breathing, and ultimately had to be intubated because he had fairly minimal respiratory reserve and was intubated for respiratory failure, transferred to our ICU. But because this was thought to largely be just a chemical pneumonitis from aspirating stomach contents in the PACU, antibiotics were not initially given. So this was his X-ray soon after he came to the ICU. He has an endotracheal tube, he has a central line, he has some cardiomegaly, and he has kind of bilateral increased interstitial markings, probably a more dense infiltrate in his left lower lobe. As the days went on, he became more febrile. He developed a white blood cell count that was mildly elevated. He had an increase in his band count. And as has become our common practice for patients on mechanical ventilation, he had significant endotracheal secretions. And so we sent off his secretions for culture and a pneumonia panel. This is just a representative timeline in this case, but true for just about every case that we take part in. We oftentimes send, no matter what, if we're going to send the pneumonia panel, we oftentimes send a gram stain and culture for identification and sensitivity purposes. And so the gram stain's back in, a few minutes really, showed an inflammatory specimen, a lot of white blood cell count, and just a multitude of bacteria, gram-positive cocci, gram-negative rods, gram-positive rods, and some yeast. Hard to know in these situations what's pathogenic, what is normal respiratory flora. This is a guy with chronic lung disease, and so that's the information that we had. But within 60 minutes, essentially almost as fast as the gram stain can be completed, we get results from our pneumonia panel. We found that the patient had Enterobacter at the lowest bin count, 10 to the 4th, Klebsiella oxytosa at the second highest bin count, 10 to the 6th, and Proteus and Staph aureus, both at the highest bin count, greater than or equal to 10 to the 7th. And in the case of the Staph aureus, the MEC-A/C and MREJ genes were positive. Within 60 minutes, we were able to decipher that gram stain and identify 4 bacterial pathogens within his lower respiratory tract. Guess what? The sputum culture confirmed all of them: Klebsiella, Enterobacter, Proteus, MRSA. The difference is that gram stain in a few minutes, pneumonia panel in an hour, the sputum culture takes 4,320 minutes. I put it in minutes for emphasis, but to really talk about the prolonged turnaround time of culture compared to the pneumonia PCR results. So the patient was immediately, within an hour of these results, placed on appropriate antibiotics. We chose linezolid and cefepime. We knew this based on some of our previous antibiotic resistance, that cefepime would likely cover his Enterobacter and Proteus specimens, and linezolid versus vancomycin would have been adequate for his MRSA. As I said, all of those 4 bacteria were confirmed on culture, and 1 day later, the sensitivity testing confirmed all of the results, specifically that the MRSA, the Staph aureus was in fact MRSA, that the Klebsiella was resistant to ceftriaxone, but the Proteus and the Enterobacter were pan-sensitive. And so at that point, we kept the patient on linezolid and cefepime. He completed 7 days of pneumonia for 7 days of antibiotics for severe community-acquired pneumonia from aspiration. And he gradually improved, was extubated, and was discharged. Okay, so my third case is going to be when vancomycin and piptazo aren't enough. So this case was from a few years ago, but it really stuck with me. A very chronically ill male, 45 years old, but much older than that physiologically, who was admitted to our hospital from inpatient rehabilitation. He was recovering from a left above the knee amputation and hemicolectomy. And then at his rehab facility, he was found to be poorly responsive with unstable vital signs, hypotension, tachycardia, and severe hypoxemia. The patient's exam and laboratory and imaging findings were all consistent with septic shock, presumed secondary to pneumonia. Marked leukocytosis, lactic acidosis, elevated procalcitonin. So the patient was intubated and had a central line placed and started empirically on vancomycin and cefepime by our emergency department before coming up. Here's his chest x-ray, which would show his endotracheal tube, his line, and his bilateral basilar nodular infiltrates. And so this is what I would consider a normal timeline if we had done things the normal way and didn't have the pneumonia PCR available at our institution. An intubated patient with lower respiratory tract infection, we would have sent off an endotracheal aspirate for a gram stain and seen this. This was his gram stain. 3+ white blood cells, 3+ gram-positive cocci, 3+ gram-negative rods. And so what do you do with that information? You probably would have continued the patient on a similar antibiotic regimen started in the ER. You can debate vancomycin linezolid, cefepime, piperacillin, tazobactam, whatever, but that would have been a reasonable first-line treatment, and then you would have waited. Within a day, we actually saw that our micro lab was finding something in his lower respiratory tract, and they resulted us that a culture was in progress, but no details, so we would have continued. On day 2, we would have found that he had normal respiratory flora and 2+ E. coli. So with that information, I think most of us would say, great, cefepime is probably going to cover our E. coli, drop the vancomycin. We think we are probably excessively broad coverage, but we're going to wait for the sensitivity testing. And then one day after that, we would have found that his E. coli was an ESBL specimen. And so finally, 3 days into his illness, we would have put the patient on meropenem or something comparable, maybe ertapenem, depending on your antibiogram. And finally, we would have had the patient on the appropriate antibiotics. Now, 3 days in is a long time for a critically ill patient with septic shock from a lower respiratory tract infection. But luckily at our institution, we have the pneumonia panel. We were able to detect E. coli at the highest bin count, greater than or equal to 10 to the 7. And we were able to detect the presence of the CTXM gene as well. And so instead of empiric cefepime or piperacillin tazobactam or whatever you want to use, we put the patient on meropenem immediately within 1 hour of intubation because the results were generated that fast. So within 2 hours of him coming to the ER, because he went to the ER, was intubated, endotracheal aspirate sent, within 2 hours of that, we had results. We put the patient on the right antibiotics. And luckily, we were able to really turn him around quickly. Although physiologically not well, we were able to get him on the right antibiotics and get him extubated. His procalcitonin trended down to a nadir of 0.81, and he completed a week of meropenem. I think we all would have to wonder, and none of us really know the answer, is what would have happened in this case if we had delayed appropriate antibiotics even a few more hours? What about several days? I have no idea what would have happened to his clinical condition, but I only can suspect that he would have deteriorated and would have ultimately had a far worse outcome and possibly would have died. And so I think this case was one of my first cases using the pneumonia panel, and it really highlighted to me the role of rapid diagnostic testing and of antimicrobial resistance data right at your fingertips. Lastly, a COVID case. This is COVID and VAPS, and I pluralize VAPS for a reason. So this is a 61-year-old male who has hypertension, obesity, came to the hospital in the midst of the COVID-19 pandemic with shortness of breath. We were able to determine that he had fevers, cough, fatigue, dyspnea 1 week prior, and he had the typical laboratory panel for patients who had COVID-19 infection, leukopenia, hyponatremic, a mild kidney injury, and his inflammatory and coagulation parameters were very abnormal. And then his nasopharyngeal PCR for COVID-19 performed in our emergency department was positive. Not very clear, sorry about that, but here's his chest x-ray. Bilateral, somewhat dense infiltrates. he's febrile, markedly hypoxic, respiratory rate in the 30s, started on high flow nasal cannula, given at the time standard of care, which was dexamethasone and remdesivir, but wasn't doing better within 24 hours. So within a day, he was on our step-down unit, was admitted to the ICU, was ultimately intubated for worsening hypoxemic respiratory failure. And again, as is our standard practice, we performed an endotracheal aspirate, we sent it off for gram-standard culture, we sent it off for a pneumonia panel, and we found the presence of strep, a galactiae at 10 to the 5th, somewhat underwhelming, but because the patient had bilateral dense infiltrates, really hard to determine what is bacterial from viral pneumonia. So we placed the patient on ceftriaxone to treat this strep species in addition to routine care for his SARS-CoV-2 pneumonia. As is typical with patients with SARS-CoV-2 pneumonia, prolonged respiratory failure, about a week into him being on the ventilator, there was a clinical change. His white blood cell count, typically in the low teens, went up to 18 to 20. He started to make more sputum, so increase in sputum production. So we again performed an endotracheal aspirate. This was a week after the last one. And this time, very different results. E. coli greater than or equal to 10 to the 7th copies per ml at the highest amount. Again, the CTXM gene was positive. And Staph aureus at the lowest amount, 10 to the 4th, and the MEC-A/C gene was positive. Now keep in mind the patient had been on ceftriaxone for a period of time, and so it's possible that ceftriaxone was partially treating some of these other species and leading to the development of more resistant pathogens. So what we did is we put the patient on linezolid and meropenem, and the pneumonia PCR results were very well corroborated by culture and resistance testing. Again, the ESBL, E. coli, was at the highest bin count, and it was cultured at 3+. The MRSA was at the lowest bin count, and it was cultured at 1+ within 2 days, and resistance testing within 3. So eventually he improved. He defervesced, his leukocytosis came down, he was weaned off the ventilator, his secretions reduced. Unfortunately, also, like many patients with COVID-19, after about 3 weeks on the ventilator, we were unable to extubate him. We placed a tracheostomy tube, and he was weaned off the ventilator gradually thereafter. Interestingly, the patient developed, this was about 4 weeks into his hospital stay, a rash, peripheral eosinophilia, an AST and ALT elevation that we actually suspected was DRESS syndrome, which we also suspected was probably from one of the several antibiotics that he had received, although at the time of this diagnosis, he was off of all antibiotics. And so he was given high-dose steroids, and that gradually recovered as well. He went to a long-term care facility, weaned off the ventilator, tracheostomy was decannulated, and amazingly, luckily, this patient made a full and complete recovery. So now I want to just go over some of the highlights, some of the limitations, and then I'm going to be done, and I'm going to be happy to answer any questions. So I think all of these cases, no matter what, highlight one key point, which is that multiplex pneumonia PCR technology is fast. It will change your management immediately and instantly. Now, why would you choose a test that is worse, so less sensitive, like conventional sputum culture, and takes longer, days instead of hours? And so the pneumonia panel is accurate and it is fast. I think one of the key points, which I hope that you can see from these cases that I've described, is that it is vital for an effective antimicrobial stewardship program. Now, without it, we know that patients often receive inappropriate or excessively broad antibiotics all the time. We also know that antibiotics are not benign. So adverse effects from excessive antibiotics, whether it be C. diff infection, increased prevalence of multi-drug resistant pathogens, toxicity like DRESS syndrome, what have you, occur in 1 out of 5 cases of antibiotic administration, even when given appropriately. So we know it's better for the patient to avoid those complications, and it's better for healthcare systems to avoid antimicrobial resistance, reducing length of stay, et cetera. And so the ability to diagnose not only the very resistant pathogens, but the very sensitive ones, and allowing you to de-escalate or possibly stop antibiotics is extraordinarily powerful. I think also you've seen in several of these cases that there is invaluable information on this panel for antimicrobial resistance. Now, the CDC estimates that drug-resistant pathogens are increasingly prevalent in the United States and globally, and a significant cause of morbidity and mortality. Now, we know that empiric broad-spectrum antibiotics are not always enough now. So VRE, ESBL infections, carbapenemase infections Community-acquired multi-drug resistant infections are unfortunately increasingly common. And so even when we think we're covering our patients excessively broad, sometimes it's not broad enough. Now remember, as I've highlighted, this assay detects resistance genes, but does not do the same thing as antimicrobial resistance testing. But I think with information about your hospital's antibiogram, knowledge of the local resistance patterns in your community, this information is extremely valuable and something that will allow you to change management on a case-by-case basis. Let me go over a couple limitations and then I'm going to wrap it up. There are cases where you have patients with polymicrobial detection. That second case that I gave was a great example. 4 different pathogens were found. But that being said, 4 different pathogens were cultured out of his lung. But this is far more common in patients with chronic lung disease, and the ability to distinguish airway colonization from true pathogenic infection will always be a clinical diagnosis. Now, keep in mind that you may have to rely on lower respiratory tract specimens like an endotracheal aspirate or a bronchial alveolar lavage. And also keep in mind that the panels oftentimes have a built-in way of weeding out the colonizers, because as you can see in this this figure, if it's detected but at a very, very, very low amount, so less than 10 to the 3.5 copies per ml, it's not even reported. You don't even hear about those. It's reported as not detected. And also if it's detected at 10 to the 4th, but you don't really have much suspicion for it, or there's multiple pathogens and one's at 10 to the greater than 7th and one's at 10 to the 4th, you're going to have to use your clinical judgment to figure out if the one at 10 to the 4th is truly pathogenic or more of a colonizer. This is the problem of overly sensitive, overly specific tests. You're going to get more information and you're going to have to kind of know how to interpret it. Lastly, on false negatives, I've already told you, not every pathogen, whether it be a virus or a bacteria, are going to be on this panel. And so it is certainly possible that there's going to be a lower respiratory tract infection that your patient has. They may have a fever, a markedly elevated procalcitonin, and a negative panel. You're going to have to use your judgment. And obviously, clinical judgment is never going to be replaced by a test like this. An expression that is sometimes used in English, garbage in is garbage out. So the quality of the specimen matters. And so if a patient is unable to give you a good lower respiratory tract expectorated sputum, if you're using BAL and you're diluting the specimen excessively with saline, you may not be able to adequately diagnose and detect a bacterial pathogen. Lastly, and I think this is an important point for new diagnostic tests, remember, no test of any kind is perfect. And I think the scrutiny that we give new diagnostic tests is a little bit unfair when you compare all of the slack that we give to existing, established, older diagnostic tests with far worse characteristics. So sputum culture is positive about 10% of the time, but people order sputum culture indiscriminately. Pneumonia panel is going to miss some tests. It's going to be false positive or false negative sometimes, but it is far superior than the sputum culture. So I hope I've shown you that diagnostic testing for pneumonia is untimely, unreliable, and we give a lot of antibiotics unnecessarily. In critically ill patients with COVID-19 infection, I think I showed you, bacterial infection is actually much more common than we initially reported based on some of the early data. And so an important subset of patients who need to be considered for a bacterial infection. And then that multiplex PCR technology can really help providers rapidly diagnose or exclude specific pathogens, leading to the ability to de-escalate or occasionally discontinue antibiotics for sensitive or viral pathogens, or escalate antibiotics in the setting of resistant ones. So with that, I am concluding my talk. Thank you for listening, and I'm happy to take any questions from here.
Thank you, Dr. Assad. It's a very excellent presentation. So Dr. Assad gave a very brief review of the pneumonia, the etiology of the microbiomes, and also overviews diagnostic tools, including the classical and new multiplex PCR technique. So how we use the multiplex PCR to identify in the potential infectious microbial. So he also gave 4 very good, very beautiful examples in a clinical case. So using the multiplex PCR to get the identification of the targeting microbiome, and also all the patients get recovered after proper treatment. So it clearly shows, the advantage of the multiplex PCR technique in the current diagnosis of infectious disease, especially in the low airway infectious disease. And also, Dr. Assad gave comparison of the PCR technique and the routine, the classical diagnostic tools, and also compare their advantage and disadvantage. And I think it's a very fair comments on the new technology. So I think it's a very, very good and very clear presentation. So here, there's some questions specifically for Dr. Assad. So how to apply the genetic resistance test? So are there any head-to-head comparison of the cost-effective of a multiplex PCR-based diagnostic in community-acquired and hospital-acquired infections, including pneumonia, and also the role of the rapid molecular diagnostic test for pneumonia for mixed infections? So, Dr. Assad, could you answer these questions for the audience? Thank you.
Sure. Thank you so much. So starting with that first one, how to apply genetic resistance testing. I think, as I've sort of shown you in some of these cases, the information that is gathered from the BioFire testing is preliminary in some ways, but it is extremely helpful. In my personal clinical experience, there have been no cases of the MEK-A/C and MREJ gene reported on the pneumonia panel. When it's positive on the test, the sputum culture has confirmed MRSA 100% of times. When it is not reported, the sputum culture has reported it as an MSSA 100% of time. So I think it is an amazingly useful piece of information, and I make immediate clinical decisions based on it. So if I don't see the gene, I treat patients for a methicillin-sensitive Staph aureus. If I do, I treat patients with vancomycin or linezolid. Now with the ESBL, the CTXM gene, with the carbapenemase genes, those are again preliminary results. If I see the presence of those antimicrobial resistance genes, I treat accordingly until I get information from sputum culture. And it is for that reason that I always I'm not trying to say that there's zero role for sputum culture, because for resistance testing, there's nothing that can compare. But I oftentimes will make a clinical decision, particularly for broadening antibiotics in the presence of those genes, and then wait for the culture to either confirm or deny. So I would kind of consider it as a quick preliminary piece of information that you can act on, but understand that it is not quite the same as your lab doing resistance testing. Head-to-head comparisons of cost effectiveness in community-acquired and hospital-acquired infections, including pneumonia. And so I think I actually showed one of these studies in my report, that there was one institution that practices in the United States at the Pacific Northwest, which had a very specific, rigorous diagnostic algorithm when they have a patient with lower respiratory tract infection. I forget all the details off the top of my head, but they always start off with an MRSA, a PCR swab. They always order a sputum culture. They always order a Legionella and Streptococcus antigen. They kind of go down a rigorous testing program. And what they did is they compared their very rigorous testing program to just ordering the pneumonia PCR panel at the front end. And they found that they actually could save money doing it that way, because instead of ordering multiple tests and waiting and hospital length of stay, then you can do one test in an hour, and that actually costs less money. What I haven't seen published in the data, what's going to be really hard to study, but all of us know is probably the case, is how much money do you save by avoiding one C. diff infection, or reducing the hospital length of stay by one additional day because you can wean them off IV antibiotics to oral antibiotics? How much money can be saved in reducing the burden of multi-drug resistant pathogens in your healthcare system by having a robust antimicrobial stewardship program and de-escalating antibiotics, and preventing one case of a multi-drug resistant infection that may or may not lead to significant morbidity and mortality? These are really hard to do in a cost-effective study, but I think that's the whole point, is that it's hard to measure that, but we know that with time, with enough patients, with enough antibiotic prescriptions, we're going to save money if we do the right thing and put patients on the appropriate antibiotics and stop them when indicated. Lastly, the role of this test in mixed infection pneumonia, and that's kind of what I went into in my limitations. You will definitely, one thing that really shocked me when I started to order this test more often is that patients oftentimes have polymicrobial lower respiratory tract infections. And it's probably because we have bunches of microorganisms in our airway, and if microaspiration of these organisms into our lower respiratory tract leads to pneumonia, it's not like one bacteria is going to do it. Multiple bacterial can do it. And so you'll identify 2, 3, and not uncommonly 4 pathogens all at once, some viral, some bacteria. And making sense of that is always going to be a clinical diagnosis. Clinical judgment is going to be required. And so there are times when people have 10 to the 4th MRSA, but greater than or equal to 10 to the 7th gram-negative rod. And if I really don't think that that MRSA is relevant based on radiographic findings, resistance testing, clinical judgment, risk factors, what have you, I oftentimes don't always treat the lower bin count numbers if I think it's more likely a colonizer and a patient with chronic lung disease with COPD or bronchiectasis, for example. And so I think it's hard to give perfect guidance, but in general, you're going to have to use your judgment. It happens more than you think it does, but sputum culture is so bad that you oftentimes don't identify any pathogens, let alone the 2 or 3 that may be growing in their lower respiratory tract.
Thank you, Dr. Assad. I totally agree with your answer, to the questions, especially for the third one. There's one more question from the chat box. I think I can summarize 3 of them. It's a very typical question: how we can distinguish between colonization and infection when we use a molecular diagnostic test. It's a very common, typical, classical question.
Yeah, and as I said, I'm not going to be able to tell you with 100% certainty ever that it is that one identified pathogen is not a colonizer. But I will say this: there are some studies of some of these panels that the higher the bin count, if you have some semi-quantitative resulting, far more likely that it is pathogenic. And that is borne out in my clinical experience as well, that if it is found at 10 to the greater than or equal to 10 to the 7, it's legit. It is real. It is not a colonizer. The question mark is for the lower detected ones, the 10 to the 4th. Could that be a colonizer? Could that be a prior infection that was adequately treated and no longer relevant, but still some bacterial DNA is detected in the lower respiratory tract infection? And the answer is yes. But then I'm gonna sort of flip that question. Do you treat every person with an elevated white blood cell count with antibiotics? Do you treat every patient who has a fever with antibiotics? I hope the answer is no, because we use clinical judgment and we compile all of the information at our fingertips to make the best clinical decision. And the same should apply to something like this. This is a very sensitive test. You are going to detect pathogens that may or may not be relevant, but you're going to have to put it together based on your understanding of the clinical picture, the other ancillary testing and data. So do they have fever? Do they have an elevated procalcitonin? Is there a corresponding X-ray abnormality? Have they clinically declined on other antibiotics? And use your best judgment to treat patients accordingly.
Okay, thank you, Dr. Assad. So clinical, judgment is also very important. So it's, compensable with molecular diagnostic tools. Okay, thank you very much. Thanks, Dr. Assad, for the excellent presentation and also the answer to the questions from the audience. So now I welcome Dr. Lam for closing remarks. Dr. Lam.
Thank you, Professor Song, for chairing the session. And I say thank you to you. And also the speaker, Dr. Assad, for giving us a lively talk and sharing on the experience on this molecular diagnostic for pneumonia and respiratory infections. They're very useful to us. I can see this enjoyable talk tonight has attracted more than 200 audience online. So thank you very much for giving us this talk. And I also like to take this opportunity to thank Biomirrors and again for sponsoring this talk, this webinar today. Thank you, Dr. Chia, for joining us today. So with that, I would draw this webinar to a close. I wish you all an enjoyable evening. Thank you very much.
Okay, the meeting is closed. Okay, see you.
Bye-bye.
Bye.
Thank you, everyone.
Bye-bye.
Okay, bye, everyone.